Just a reminder to silence your cell phones if you haven't already done that.
I'm listening to the radio pieces. That's all the year.
Oh, okay. Sounds good. I believe it.
Well, good afternoon, everybody. It's now 2:00. We'll call this Bridging the Gap Subcommittee meeting to order. First item of business would be approval of minutes. Do we have a motion to approve the minutes?
So moved.
We have a second.
Support.
It's been moved and seconded. Any additions, corrections, questions? Not seeing any. All in favor signify by saying aye.
Aye.
Opposed, same sign. Thank you. I see no old business before us. Anybody have any old business? No, we're good there. Well, great. Then we'll jump right into our presentations. We'll begin with actually 3 presentations from this entity, Parkside Family Counseling, and it's Therese Langen. Is that correct?
Yes,
All right. Thanks so much.
thank
It's up to
you.
you. Yep.
Thank you. Okay. I'm Therese Langen. I'm the owner of Parkside Family Counseling, and I know many of you, a few of you I don't know. I am here to present the 3 proposals that we put together for the opioid funds. I am not a natural public speaker, so have mercy on me. I'm going to do the best I can. I am really passionate, though, about substance use prevention and treatment, especially for young people. So what we know in this world in which we live in now, that most people who struggle with addiction and opioid addiction specifically began their use of substances before they turned 18. People that struggle with addiction over their lifetime often started before they were 14. And if you start before you're 14, and many of you may know this, you are more likely to struggle with addiction in your lifetime, throughout your adult life. The services that we have available, though, in this community for young people, I'm going to say, are very slim. Parkside has some of the few services that are available, and oftentimes people don't even know how to access the services. So what I'm going to talk about today, 2 of our programs that we are presenting here are for youth, and one is more specifically for adults, but also is important. So I will just start with number 1. So the Unified Prevention and Intervention Program is for teens and families, and it really speaks to having an equitable availability of services to families and with teenagers in need. The program is really to combine trauma treatment and substance use treatment. So because there is such an overlap with those 2 problems, kids who have experienced trauma, young people who have experienced trauma, oftentimes move to substance use in order to cover up the feelings and the memories that they have. So that's why those, of course, need to be combined. What we're talking about in proposal number 1 is services being available to people, even to teens and their families, even if they're not involved with child welfare or the juvenile justice system. Oftentimes people get their services because of their involvement with the juvenile justice system, with adolescents and families through child welfare. We often get calls or we get requests to do some more intensive services that aren't available because the youth is not in trouble with the law. So there's been many occasions where we've really kind of had to help walk people through becoming involved with the juvenile justice system simply so their kids could get treatment. And that's really not fair to the kids or to the system, honestly, because we don't really want kids to feel like they have to be bad in order to get help. And because they're using drugs or they have experienced trauma and have turned to drugs or other substances, doesn't make them a bad person. And so, unfortunately, getting somebody involved in the juvenile justice system can really make people feel like, well, I'm just a bad person, so I might as well just go ahead and go one step further, whatever that one step is. The program is a comprehensive trauma-informed program to be able to address substance use disorder, opioid use disorder, if they're already using opioids. Their families are involved, so the early intervention is very important. They will have also peer support, therapy, and case management. So we're talking about an entire array of services that have been known to be helpful for young people. Sometimes people think, well, if you're in the community and you have access to therapy on an outpatient basis, why isn't that enough? Therapy for kids that maybe don't really want to be a part of it, if you're accessing them only in your office, the chance of them being present on a regular basis consistently so that the treatment can really happen, that the issues can be addressed, is very slim. When you have therapy that could be accessed at school or at home or in the office, depending on the situation, you aren't setting up a barrier because the family doesn't have transportation or the parent doesn't want to argue one more time with that child to, it's time to go to therapy. The other thing that we found out in doing home-based therapy, which is what Parkside really started with, is the juvenile justice system and home-based therapy, is that you make a lot more progress in a shorter amount of time. And that is because you get access to all the people that are important in that child's life. Now, they may not come into the living room or wherever you're sitting right away, but we all know that they're standing around the corner listening. And when they feel like it's time and they feel like it's safe enough, they're going to join the process. You would never have gotten those folks involved if you didn't have access to them at home. The other place that kids spend the majority of their time, if things are going the way they should be, is at school. And if that treatment provider who understands trauma and the overlap with substance use could be available wherever those kids are and wherever they need. In this program, we're talking about maybe 6 to 9 months worth of treatment. They could be accessed much more easily, and they're going to get the help. The interesting thing, the very special thing about this program is that we're saying that you don't have to go through an entity that you don't belong in, like juvenile court or child welfare. But the referral process could come from any child and family serving professional who is involved with that child and sees the problem. We have an intern actually who works at the Boys and Girls Club. And as I was practicing what I'm doing right now, he said, we had a situation like that yesterday. And I'm sure it happens all the time. A principal, I talk with the assistant principal, Jack McGurk, at Adrian High School all the time. He refers kids to me to be able to do a substance use assessment. And if they come and take advantage of that, I give their parents the array of services that are available. They knock off a couple of days of suspension. We'll get more into out-of-school suspension and proposal number 2. But the idea that maybe Jack McGurk has really a good sense of this family's in trouble. There are 3 other kids. They could be in trouble too. They need help. So if he was able to make a referral to me, not have to, try and drum up something to get the child involved with juvenile court, I could do an assessment. I can see if, yep, Jack, you're right. This is appropriate. The parents are on board. The parents say, we didn't know how to find you. Now we know. Okay. If that person, the other thing that I think about is patrol officers, deputies, they're out on the road. They have to deal with so many juvenile involved situations. And they get to see the home, they get to see what's happening out in the community, and they know that there's something else. These are not just bad kids. Maybe there's lack of supervision, maybe there's too much access to who knows what. What we're talking about in the Unified Prevention and Intervention Program is being able to have an array of services available to the youth and family. And the majority of the budget that we proposed really goes to hiring staff that are professional, that know how to address substance use disorders and trauma, and can get out into the community and do what's needed to be able to help the kids where they're at. The mode of being able to use community-based, home-based services, incorporating trauma-focused treatment is evidence-based, using the types of interventions that we use that are evidence-based, like motivational interviewing, cognitive behavioral therapy, that would be a part of this. And home-based is a real important part of really making things work as well. I'm sure I'm missing some things, but you can ask questions.
Thank you. Any questions? I have a number of them, but I would love for you guys to start. Commissioner Collins.
Your proposal states that the capacity, if you would, is 10 to 21 use. Is that use and the families and the other support systems or other personnel?
Yes, so one client would be that youth and the people that are important to them.
One more, you cited the fact that you have worked with personnel in schools. Do you have support for this program within the school system?
We only just started talking to Adrian schools, but yes, we have support for that. We have number 2, we've been talking a lot about, and I'll get back to that soon, but we have really good relationships with the schools. And mainly that is because of the intensive home-based therapy. Intensive home-based therapy, the way that we implement it, takes place wherever the child is and wherever they need the help. So we spend a lot of time in schools and in the home when, depending on the kid, it might be at the Boys and Girls Club, it might be somewhere else. But we have a contract with the Lenawee Intermediate School District to have mental health professionals in a plethora of schools throughout the county. And that helps kind of keep us knowing what's happening in those schools and what kind of help they need, what kind of problems they have.
Yeah, it's obvious if you go by your facilities, the majority of people you see coming in and out are young people. So
yes,
youth is the basis of your program. That's what you deal both with is.
Well, we deal with, we definitely treat adults as well
Right,
and families, but yes, I mean, our basis is really working with kids, especially adolescents. So teenagers with trauma and teenagers who have gotten into substance use issues and just basic family issues as well.
It's refreshing to see a program specifically, if you would, designed for youth. My personal experience, it's probably, I was being naive. I was a cop and I didn't see the signs of my own son.
Yeah.
And the school system, which has really become a long way since then, at that point, just pretty much wrote him off.
Right.
So there was no intervention there. So there's no support, no intervention, and obviously the progression went on,
Right.
so forth. So I
And we have
Well-
found that there are a lot of administrators and professionals in the school system that would like to do more for substance use problems. And they just don't have the resources in the schools to be able to do that.
like it a lot.
Thank you.
Tim and then Sheriff Bevere.
Quick question. You talked about in the core program at Jeff-T's empower youth through peer-led mentorship and recovery-oriented engagement. Just really interested in hearing how you're going to, what you can do to get those students, what you're thinking, to get those students to take leadership and empower them, give them an agency to be able to be stronger moving forward away from their substance use.
Well, we see that in groups all the time. So we have groups for various ages for girls and young women who have experienced sexual trauma. So they're survivors of sexual harm, and the groups are just incredible. So so with this program specifically, if we have people that have had trauma, but they aren't necessarily have been sexually assaulted. They have other kinds, there's all kinds of trauma that we assess kids using the ACEs scale, so the adverse childhood experiences. And so many of those are things that happened when they were very young and had absolutely no control, of course. So getting kids to become leaders in their treatment groups, that is very common, but also pulling in other kids that they know are hurting or maybe starting to use substances that they know there's something behind that. And, you know, we have seen over the years with the survivor group, so many young girls that they just drag their friends in. She needs this group too. And that's how it gets started. Because they didn't have the courage at that point to tell, you know, so.
Sheriff?
You mentioned that you do have adults, and I was wondering, I can't remember if you've been in our jail before and did programming, but does this program talk about doing programming?
Does it talk about what kind of program?
Doing programming in the jail or reaching out to the location like the jail? Or is this all voluntary people coming in?
This program isn't specifically talking about the jail, but actually, there have been different times when we've had the availability or wanted to be able to get in jail. I have been. So I actually did an intensive home-based therapy program with the juvenile court where I went in and met with the mom who was in jail to be able to kind of get things started to really understand her perspective, because that was important too. That was a long time ago. It's been a while, and yeah. So interfacing with people in the jail makes a whole lot of sense to me.
Thank you.
Mm-hmm.
Other questions? I have a couple. Tim, did you have another one or? Okay. First of all, some more mundane stuff. How many people do you employ currently? How big is your staff?
So currently we have about 6 people that are employed, and we have about 15 people that are contractual therapists.
Okay, wow, so that's a good number. And if I read this first proposal correctly, you're asking for $250,000 roughly for a year?
Right.
Okay, got that. Is this is this proposal an enlargement of something you're already doing, or is this a brand new program?
This would be a brand new program.
That's what I thought I understood.
Mhm.
Now, because of your broad experience, you realize we have two levels of tasks here. One is to analyze your proposals, right? That's our job today. However, because you have a broad base of experience in the community, and we also have to assemble a whole package when we're done with this, a very daunting task, I thought I'd take advantage of your knowledge while you're here and ask a couple questions. Do you think, I mean, we've had a host of proposals and many more to see covering all kinds of areas, from transportation to marketing, communications, to various types of app-based services, personal services, some that are a result of people having been in the courts and picking up there, other in yours looking more for preventive and maybe not necessarily as a result of legal action. Do you think the three areas that you're proposing, why did you pick those? Are those areas that you think are particularly vulnerable, or areas that you think you can have a significant, or are there other areas we should be looking at too, just based on your experience?
Based on my experience, there's not enough in the community for teens and teens and families. And so when we started doing this and brainstorming, everybody at Parkside knew we weren't going to get away without doing some kind of youth programs, because that is where my heart is. But working with adults as well. So the reason that I chose our proposal number 3, that area, is because the services that are available to any person, adults typically, are not the same based on, it's really unfortunate that it's based on kind of who you are because of what kind of insurance you have or what kind of insurance you don't have. And so, like with proposal number 1, kids that can't get involved in really intensive services until somebody says they did something wrong and they're involved with the juvenile court, or their parents get a CPS call on them, they're involved with child welfare. And so the idea that we see so many people in need, 1, they don't know how to access services, but 2, the services really aren't available to them.
Mhm.
So I think actually, I'm a collaborator. I talk to people all the time. I just met with a kid over at the Laura Haviland ISD school, and the social worker there, I think she's been married a couple times since. She has a different name, but we realized that we still had each other's cell phone numbers saved on our phones because of something we did together in the early 2000s. So it's really easy to reconnect with people and to be able to talk to people and say, hey, this is something that we could do when kids so if like when Adrian Public Schools, the high school, calls me and says, hey, we've got this kid, we just suspended him. His weed pen fell out of his backpack on the way into the bathroom. Boom, 10 days. But if he comes to see you, he gets 3 days taken off his suspension. Okay, now this is a kid in high school who maybe is a little bit on the edge anyway. 7 days out of school is still a lot of time. And that's pretty common throughout the county in all the different districts. I feel like I'm kind of morphing into the answer for question, to explain number 2, but the idea that if you could call us and say, can you get somebody over here at school tomorrow or the next day, we're going to sit in the in-school suspension room and we're going to review the curriculum you just went over, this evidence-based curriculum that was developed at Stanford University. And they have a huge program that simply creates curriculum and then studies the curriculum. And this is a program specifically set up to reduce or eliminate out-of-school suspension. So the idea then is that we're going to put three things in this family's life. We're going to give them information about drugs and alcohol and why it's really not good for you because you're 14 years old. Things that you can do to get support and where you can go for help. We're going to do a screening, brief intervention, and referral to treatment. And that's where we're going to connect with the parents who said, I didn't know where to take him. I didn't know you had this group on Tuesday night. I tried to let, people know we send out invitations and flyers to school counselors every year, trying to get, let people know so that it's out there. But through the screening and the brief intervention, that's again an evidence-based protocol. We use the CRAFT that is well known and used across the country. We put that into place, and then we're able to see, I think this kid might need a full-blown assessment. Or, you know what, if we put him in this group and we get him this therapy to help deal with the mental health issues or maybe the trauma issues, we're gonna address what's needed. But now the parent has access to me, and I can say, they can ask me questions. They can say, well, what about this other problem? And then I've got this little one here who's still in middle school, but he's found Big Brother's footsteps. Okay, maybe they need more. Maybe they need something more like program number 1. So that everybody can get a little access to services and help and answers and just be able to talk about what's going on in their life. One thing, I guess I've got time, kids start with nicotine. They don't smoke cigarettes anymore. It's all e-cigarettes. I haven't been inside Ronnie's or any other party store, but I hear that there's like a whole wall of e-cigarettes available. And depending on where you go and what time you go, kids can access them pretty easily. It's still nicotine, and it is still one of the most addictive drugs out there. It is where people start when they start walking up the line to marijuana and then to harder drugs and end up with opioids, ultimately heroin. They start with nicotine. They start with the e-cigarettes, and then they get caught and somebody says, stop it. If you know any adults that smoke, is it easy to stop? It's not easy to stop. And if your little brain started getting nicotine in it at 11 or 12 or 13 years old, by the time you're 15 and somebody caught you and says, stop it, it's really hard. And, sometimes kids are even getting put in MSC detention because they keep coming back with positive nicotine result tests. But they're not being given the help to be able to stop it. So there are programs now that seem to be useful, and we're trying to get them, made them available to people because kids text. Some of them are texting or apps that kids can engage with this support system and be monitored by their parents or somebody, a helpful adult, to be able to say there's other things that you can do besides go and vape right now.
Now, I heard you say that one of the issues, and we've heard a couple marketing proposals, that you have programs, but one of the struggles you've had is to make people aware of those programs. How much more capacity do you have in your existing programs if certain types of marketing were able to push people your way? I'm not holding you to a number, but just,
we definitely have capacity in our group. So we have a support group once a week that is for teens and their parents. So we have 2 therapists who are present the groups are sometimes separate and then they're also brought together because one of the things that's evidence-based for kids not using drugs is their relationship with their parents. So we work on communication, we work on, parenting in a way that is more, helps kids to want to talk to their parents and want to, let them know what's on their mind and what's going on and why they're moving towards, substances.
Sure.
Excuse me.
Sure. Okay. One question to the rest of the committee, mainly because of my faulty memory, is this, we've only heard, I think, one other proposal particularly targeting young people. Wasn't that the STOP program from the courts? And was that or was that not obviously since it's the courts, those are people that already had encountered the legal system, right? So this is a parallel to that and hopefully a prevention towards that next step. Good. Terry, and then we'll go on to your next presentation.
Oh, I'm sorry.
No, you're fine.
If I could kind of boil this down, your position and your belief is that if you're able to get intervention, not only with the youth, but with all people, family and others who impact that individual prior to adjudication or school referral or other kind of stuff, your chances for success are far greater than waiting for another year or so until the court says you will go to.
With most kids, I believe that, yes. I mean, yes, there are some kids where the parents are not necessarily going to be on top of this because they've got complications in their life. Like, there's a number of different reasons why. But if kids can change before they're labeled as bad and they can get the services they need at that point, the chance of really being able to get those kids then into the things that other kids are doing, like sports and music and drama and other community, possibilities are better. It's harder to get a kid involved in the juvenile justice system who's done, a number of things wrong. It's hard to get them into sports, because they've got so much else they have to do now to work their way out of the system.
Got it. Well, thank you. Very enlightening. Thank you for allowing us to ask some questions that maybe weren't directly on point, but hopefully deepen our knowledge as we put this whole package together. So
Sure,
if you want to go ahead and start with your next presentation.
sure. Let's see. So I sort of talked about number 2 a little bit, but so number 2 is the reset for success, getting into the schools and being able to offer information, brief screening, and then a motivational interviewing type of format of a group to be able to talk with kids about 6 times. A little time limited. If the kids really like it and they're gaining something from it, they could re-up for another 6 weeks. The idea, though, is that right now, most schools are simply suspending kids for their use of substances. And that, now, Stacy Soto, who is the Dean of Students at Springbrook, actually had already accessed the Healthy Futures, which is from the Stanford website. And she put that into place in the in-school suspension room after the out-of-school suspension. And when I started presenting this to her this summer, she said, "Oh, yeah, we need you in the room. We need you in the building because we don't have anybody that understands what they're learning and can ask the right questions to see if they actually did it." That what they have to do is go through this curriculum and out comes a certificate saying you completed it. They give it to the principal and then they're done. And she said, "But we need you in there to then talk about it with them," which is exactly the plan. The plan is that you have a first offense, let's say, of having drugs in school. You run through the hour-long curriculum. Then our professional comes in and talks to you They do the brief screening, the SBIRT screening, brief intervention, referral to treatment process. If more is needed, they're contacting the parents, they're being able to make referrals to maybe get a full-blown assessment, either through community mental health if they can access those kinds of services, or through Parkside or anybody else that does work with youth. And then offer the services. Now, some of those kids maybe even need residential, a rehab program. There are not many rehab programs available for youth. And I mean, it's really pretty dismal, actually. We accessed a few different times with the help of community mental health, a program that's up in Marquette, Michigan. And we have known of at least 6 or 8 kids that have gone there from here. That is really hard for parents to be able to get there. Of course, we have Zoom now, thanks to COVID. So the family sessions can still happen, or the visitation or whatever. But that's the only program that CMH could access. There used to be one in Saginaw and they closed. And then if you have commercial insurance, it's actually worse for kids in Michigan. There isn't a program that will take your commercial insurance in Michigan. Pinecrest takes, or Wedgwood takes commercial insurance, but really only from people in the Grand Rapids area, because they don't need to come outside of that area, and then they can do more with families and such. We've known of people that have gone to Kentucky with their kids. We know of a couple other places, but that makes it so much harder to be able to really be a part of the solution, which is what parents and families need to be as part of the solution. So I think I digress there. But being involved with, so let's say, kids don't just stop when you tell them to stop once. So the Stanford program really is set up with 3 different levels of presentations, information, so they keep getting more detailed. They have more of an interactive, the third one that's can be up to 6 hours of learning, but you're also interacting with the youth who's doing the presentation, and then they have things that they have to write about so they can start processing what they're learning. And then from that, so the schools could call us in, let's say, maybe on 3 different occasions. I mean, at that point, we might be saying, oh, wow, mom and dad, I think they need something a little bit more than just what we're giving them in the school. And then we're going to start working on accessing those services. Let's see.
So part of this really is a triage effort where you find the kids early and then help to identify where they.
Yes, it is a triage effort, but the other thing about it is that the kids, if they're suspended from school for 7 to 10 days, oftentimes they lose hope on the semester period, but they might be just hanging on by the skin of their teeth. And now they're out of school for over a week and they just give up. And then you start to see the, drop in enrollment. You see, kids just saying, never mind. Maybe they go to an online program because that's easier to do, but there are a lot of kids with complicated learning styles, and doing high school or middle school online is really tough for many kids. So keeping them in school. So even if they're out of class for a couple of days, they're in the in-school suspension, but they're talking to somebody about their health and well-being and about making better decisions around substances, and then getting back in the classroom. And then maybe for 6 weeks, they're going to come to you during lunchtime. That makes the most sense to me. But the schools can decide, what really works best. And then they have a new support person in their world to be able to go to when they have troubles or they, have new situations that they're having to deal with. And I think that the parents would really like it because oftentimes the parents are caught unaware. If they have really complicated, busy lives, they don't know that this kid is using or even interested in using, or, they think maybe they told them to stop it. And so then they did. The other thing that people aren't realizing, they're starting to realize now, but with the multiple strains of marijuana in Michigan now that are legal, it is really easy to be able to get addicted to marijuana. It is really easy, fortunately, to access it. And some of the problems that can develop because of marijuana use are really big health concerns. Cannabinoid hyperemesis syndrome, also known as CHS, is uncontrollable vomiting because of an excess of THC in your body. It happens more to younger people. And I've known of about 6 people between the ages of 14 and 22 who have experienced this. The 2 youngins that I know that experienced it ended up in the ICU at U of M because it was messing with their electrolytes, their heart, and their kidneys. And the only way to stop it and prevent it from happening again is not to use marijuana anymore. So the other thing that we have seen happen, and we understand that people are dealing with, is psychosis that is induced by marijuana use. So extreme use of marijuana, very constant and in the body, that can really start creating a serious mental health problem that sometimes has been able to be changed, be eliminated, be treated, and sometimes it's not. It kind of depends. So, I mean, those are just a couple of things. EVALE is e-cigarette induced lung problems. So lots of kids you see in schools, you're not old enough to buy an e-cigarette, but your friend who you meet in the bathroom at 11 o'clock break sells e-cigarettes that he's just kind of recreated from old ones. Well, those are the ones that are the most dangerous because the pieces of metal in those remade e-cigarettes can come out when you inhale, and then those little pieces of metal are in your lungs. And that's when you hear about some pretty outrageous things that happen, but I mean, they're real. They happen, that people have serious lung disease and reduction in the capacity of being able to even breathe. And so all of this stuff is happening in middle school and high school all across America. And, saying, well, you're a naughty kid and you're being suspended from school, it just doesn't seem to be the congruent reaction to what's happening. So getting more information and being able to help people understand. And when kids have the right information about keeping themselves healthy and on the right track, they typically make better decisions. What we know is to just tell them to stop it doesn't work. But when you say to them, you have hopes and dreams in your life, and what you're doing right now, read it. It's right here, kid. This is diminishing your capacity to be able to be the person that you want to be. And I have some ideas if you want me to tell you, what kind of things you could do as a kid instead of smoking or vaping or, whatever. So, yeah,
Okay.
I guess I'll stop there.
I'll jump with one and then I'm sure others will have. So your budget is, request for this is $144,000.
Right.
And I see you're talking about a pilot program in Adrian and Madison.
Yes.
So my question is, if this rolled out to more schools and so forth, what would that do to your budget in the future? And is there any thought that any of the schools would be able to, in the future, partner with you financially on any of this? Or is that, I know their budgets are tight too. Just wonder what your thoughts are on those areas.
That's the one that I have the most hope for sustainability going forward, whether it's the schools or the intermediate school district. We've been contracting now for 2 years to do universal prevention with the intermediate school district. So the primary prevention, tier 1, that's available through the Stanford website. It's for 7th graders. We have not hit every single 7th grade grader in Lenawee County, but we're really trying. We have also piloted a program in the 5th grade because there's also an elementary level presentation, and that's a little bit more about healthy bodies and healthy communities. So it's, it's age appropriate talk about substances. So we've been doing those, and I think that the ISD has been pretty happy with the idea that they are able to offer this. This kind of a program could really, if it works, it could up the graduation rate. There's less kids are gonna need to drop out because they haven't been put in that hopeless situation of having these big, huge chunks of time taken out of their semester because of their substances in school.
Other questions? Well, with Sarah?
Thank you.
Mhm.
Actually spoke to my daughter. I have 2 daughters. My younger daughter is a graduate from Adrian High School. So I wanted to consult with her. She's in her 3rd year of college now.
Oh, good.
So, and a lot of the stuff that you said, she said as well. She said she noticed a rise of vaping in middle school. Kids go into the bathroom and vape. That's evidently the vaping space at school.
Evidently.
Yeah. She thought that education to take away the cool factor, because like you were saying, you can't just say to the kids, stop doing this, it's not good for you, because then they rebel.
Yeah.
Whereas if they were properly educated in a manner like you were speaking, if you could take away the cool factor, tell them real stories, give them real information,
Right.
perhaps that would make a difference. So she also said that all the students need it, not just the kids that are in trouble or whatever. So how are the students going to know about this program if they're not the student that is in suspension or thinking they might be in suspension? And also, how will the teachers be able to support your program?
So part of the plan is really on the front end doing some marketing, both with the schools and the principals, the staff, but also with the parents, the parent group, sending out, being able to use the email lists or however the school gets in touch with all of the parents so that they know that the program's going to be available. Because if there is a student who has a problem, we want them to be involved too. They don't have to bring the drugs to school in order to get into the program. So that is a possibility. Now, we are hoping that if we get to all the 7th grade classes year after year, let's say in 5 years, most of the kids are going to know a lot of this stuff. So there are some kids that don't know that. And, I just talked to a kid not too long ago who was telling me about his drug and drinking use. And then I said, well, and the craft screening says in the last 12 months, on how many days did you vape or use any other kind of nicotine products? And he said, oh, yeah, I just vape for the flavor. I get the ones that don't have the nicotine in it. You're still ruining your lungs, but it tastes really good. Okay, so I mean, that's where we kind of need somebody who's more politically minded and can lobby, in Lansing or something about, the marketing of these, because the vapes with flavors are marketed to kids. There's no, it's really, there's no way to say it any other way. And so, it does seem cool. Oh, let me taste that. Oh, wow, that does taste like strawberry. That's interesting. And what about yours? Oh, yeah. Yours really tastes like, popcorn. Oh, right. Well, the chemical that goes into the one that tastes like popcorn is actually a cancer-causing agent. But it tastes really good. So, yeah, everybody needs to know. So, that's why we started with the intermediate school district with the primary prevention. Just get it to everybody. And some of the kids that we get to there, they already know all the stuff. They've already been doing it, but a lot of kids don't. So 7th grade is a pretty good age. And then we're just starting to move down to the 5th grade.
Other questions? Gary?
How do you separate your first program from this program? Because you're trying to help both the same
Both
groups, right?
sets, right? So
And you got one
the
outside of school and inside of school, and I mean, if somebody just go to this in-school one, and maybe I know you're not going to have counselors in every school system.
Well, the in-school one, number 2, really is, I mean, somebody said triage, and in some ways that is what it is, because you're really getting the first chance to look at this kid and maybe at their family and kind of see what's happening. So the first program is a lot more of a therapeutic service. That is, and the big thing about that one is that it's going to overlap trauma and substance use. Whereas this one, you only have 6 times we're going to meet with you. We're really trying to motivate you to make different decisions around substances. We're not trying to tell you to stop using. We're trying to get you to make healthier decisions around substance use. Now, ultimately, it'd be great if you just stopped using, but we're not going to say, just stop it. But we're going to do a lot more in-depth treatment with the first program.
So you could take somebody that was using your in-school program and move them to the out-school program if
It's
felt
possible.
like they needed the additional.
It's possible. If they don't have it accessible any other way, they're
Right.
not involved with the juvenile court system, they're not involved with child welfare, they would be somebody that would probably be a candidate for that.
Gotcha.
Mhm.
Thank you.
Sure.
Anybody else? Okay, well, I guess now you got program 3.
Great. Okay. All right. Hold on. Okay. Program 3 is engagement for all. So when we started doing substance use disorder services and got a contract with community mental health, we learned about the ROSC system of recovery. We learned about what, different ways to be able to reach people. Therapy is one of the ways, but engagement with people who have lived experience, so the peer recovery coaches is something else. And then we look at people whose lives maybe started falling apart. So case management and being able to help people get a place to live, be able to figure out how to access a job that's going to sustain them, and being able to get other services, finding out how to get food when you're out of food and getting insurance and signing up for benefits. That's case management. Having those different levels of service has been helpful for most of the people that access services. Those types of services, the engagement, call them engagement services, are not available to be paid for by anyone except CMH. Everyone can't access CMH services. And so in our Parkside world, if somebody really needs it, I just say to the case manager, the recovery coach, just set up meetings with them. Invite them to the groups. That is not the universal way that things are done, but I'm personally not going to hold back and not give someone a service if I think it's going to be helpful because they have commercial insurance and their insurance isn't going to pay, and they're already feeling nickel and dimed by their deductible or their copays. I can't really charge them for it because they don't have the money. So I'm going to offer them those services. So I think that everybody should be able to have those services. And I think that I should have a better business model than to not have a way to reimburse myself for the time that I let people use those services. And they're really not even, no one's going to pay for them. It is a good model to be able to have different ways to access what you need because everybody doesn't need the same thing, and therapy is often not enough for somebody with substance use disorder who oftentimes has trauma anyway. I was telling you about the Tuesday night group that we do with the parents and the teens. That's another one that we do at no cost to the community because it's very hard to be able to, it's hard to get people to come if they don't really have the money anyways. And so being able to allow everybody to come under the same guise that, this is just a service that we're offering the community. So I really don't know how many other agencies that do substance use disorder treatment and have peer recovery coaches and case managers give that service out to people without support through CMH. But when I was involved in the recovery court team years ago, it seemed like it was not typically accessible to people who did not have their services through community mental health.
Great. Any questions? Brenna?
Is this on? Yes. Okay, thank you. Just, could you expand a little bit more on the challenge for accessibility when it comes to payment? So having a payer and qualifying for payment. Yeah, that is something I didn't understand probably 4 or 5 years, well, maybe 6 or 7 years ago.
Okay.
And I don't know that that's commonly known. And I'm especially intrigued as you answer that this particular proposal would provide recovery services to 75 plus privately insured adults annually. That's a large number.
Mm-hmm. So, I mean, most people work, and lots of people have access through their job at a factory or wherever to commercial insurance. So they have Blue Cross or Priority or something like that. We also know that a lot of those folks have very high deductibles. So they are living paycheck to paycheck, and their deductible maybe is $2,000 or $3,000. So to be able to really get the things that you need, a lot of those folks don't use their insurance. They can't. Oftentimes, actually, we have a lot of interns from different schools in the surrounding area. We have master's level interns once they're at a certain level of competence. if we have somebody come in who says, yeah, I can't pay for this, we will offer them an intern to be the therapist. That's the best we can do as far as that goes. But engagement services are not covered by any of those insurances. And to get the services through CMH, you also have to meet a certain criteria. So typically people with Medicaid are eligible for CMH services. There are actually a lot of people with Medicaid who might, for some complicated reason, have a secondary insurance. If that is the case, you cannot access the CMH services for substance use disorder treatment because you have a private insurance. But you can't pay your deductible or your copays. So now what do you do? And that is a real struggle for a lot of people who try to access services. I mean, I am glad that the CMH system is available for the people who get the service. And then they have access, to the whole array of services. But that's not everybody. A lot of people don't get what they need because of that.
Other questions? Well, thank you so much. You've given us a lot of information. I appreciate your patience with our questions. And,
Your questions were great.
oh, super.
Made it easier. I work with questions.
Super. Thank you so much.
Okay, you're welcome. Thank you.
Well, we're quite a bit ahead of schedule.
We have
Well,
a short pause for the cause, Mr. Chairman.
would you like a short pause? That would be fine. Let's take a 5-minute break. All right, we get back to business here. It's my pleasure to introduce Dr. McCord, who's going to share with his presentation. He's from Opioid Free America.
Okay, thank you, Mr. Martis. Thank you for allowing me to be here today, and it's great to hear that we're actually ahead of schedule. I'll try to be as efficient as possible with everybody's time in this beautiful fall afternoon. I'm from Michigan. I'm a Michigander. I'm from the Brighton area. Drove down 52 this afternoon. I saw no deer, thankfully, but I saw some big tractors, and it was lovely. What a great drive. It's beautiful out here, so good to be here. And I'll try to get you outside as soon as I can. I'm Dr. Matt McCord. I'm a physician. I'm an anesthesiologist. I'm in clinical practice currently. I'm at University of Michigan at Sparrow. That's a level 1 trauma center in Lansing. Most of my career I was down in Ann Arbor, forgive me. I'm a recovering Ann Arborite. I was there for about 28 years at the Trinity Hospital. And I was an educator and am an educator. I educate residents and train physicians in training often, probably 2 to 3 times a week. I'm also the co-founder and executive director of Opioid Free America, which is a national nonprofit based out of Las Vegas. And we're doing a lot of things in a lot of states, and I will be telling you more. What you heard earlier today may have been more, I kind of looked at the agenda. I think that first part was about prevention, but the last part was more about mopping up the floor. I'm talking about how can we turn off the faucet with our opioid crisis, and I'll tell you more about how that happens and the innovative technology we're using to do this. Next slide. Thank you. Thank you for that, whoever switched the slides. Well done. So we're about preventing addiction and protecting tomorrow for Americans. We're a national nonprofit, as I mentioned, and our AI-driven platform identifies risky prescribing patterns, engages prescribers directly, that's doctors, and their PAs and nurse practitioners, and delivers measurable savings while saving lives. So importantly, I think I'm going to mention some things, and this will come up in the discussions, I'm sure, and the questions. But 1 in 3 Americans, unfortunately, has a personal story about opioids. 1 in 3 Americans. Okay? It may be a friend, it may be a neighbor, it may be a family member. For too many, it began in the doctor's office with a prescription meant to heal that actually caused harm. So what I'm saying is America's opioid crisis does not start in the street. It actually starts in routine care. And I'll explain more on how that's happening. Next slide. So this is some of your data from what we can gather based on national data sources. You actually have a prescribing rate about 28.6 per 100 residents. 75% of people that abuse opioids on the street today started with a legitimate prescription. There's really good data out there about that. Let me repeat that. 75% of abusers that are on the street in San Francisco, LA, wherever, in your communities, started abusing drugs with opioids with a legitimate prescription, okay? Fentanyl actually is our sequel. Overprescribing is the prequel. That's where our crisis begins, with this overprescribing of opioids that happens in ERs and doctors' offices all the time in America. So the villain in this story isn't the patient, it's the system. It's the legacy of overprescribing that hides inside every health plan's claims data. And we're going to tell you how we see that and how we can speak to that right today. For example, in this community, farmers, very physical work. They get injured a lot. I've taken care of many of them, actually, being flown in by helicopters, both now at Sparrow and in Ann Arbor. They're exposed a lot to the healthcare ecosystem, and we often prescribe opioids. That's why, for example, in America, construction workers have a 3 times higher instance of opioid overprescribing than the average American, because opioid exposure is an occupational risk for those individuals in America. Same is probably true for farmers. That's why I'm really curious to see the data from Lenawee County. Next slide. So what are we doing? So we can take any claims data, healthcare claims data from any employer. You guys are employers at the county level. You have a health plan. You have claims data. We could take your claims data and then put it in our platform and look at opioid prescribing patterns within your workforce or your community of workers. This is the beginning of what you might have heard of as population health. We could take that and assess your opioid burden in our what we call our opioid impact assessment. And we use AI predictive analytics that tell us what prescribing patterns are dangerous in your community. Now, we are doing this with de-identified claims data. We're not identifying any of the individuals within that health plan. We don't need that headache. We actually are using that only as a data point. Who we identify is the prescribers. And when they're prescribing dangerous levels of opioids, we engage with them directly in a peer-to-peer way, physician to physician, nurse to nurse, PA to PA. And we say, look, are you following best practice CDC guideline standards on opioid prescribing? Are you tapering off opioids? Are you instructing them how to do that? Do you have opioid contracts that you're having them sign? Are you having these conversations in the physician's office where it needs to happen with that individual to make sure that they're getting off opioids in a safe manner and quickly and tapering appropriately? We also are identifying benzodiazepine use like Xanax and Valium, which also don't help the problem and actually exacerbate or make worse the likelihood for overdose. So that's our targeted case management. We engage with the prescribers. And there's a direct employer benefit to that shows that it lowers overall healthcare costs for the benefit plan for that sponsoring employer. And again, I'm calling you guys employers too, okay? Since you guys have your own health plan. There's also a secondary indirect community health benefit because obviously these same prescribers prescribe to everybody else in the community. And so we're lifting all boats. So now that they've been educated on best practice prescribing, we've also given them tools to make that job easier, to hit the easy button for doing the right thing. We found in a number of communities, I'll talk more about this, that there's over a 90% adoption rate by doctors when we engage it with them in this way. They want to do the right thing. They have about 4 minutes with you, so they're usually doing the easy thing, and they're trying to get you out the door, which many times includes, here's a prescription, thanks very much, we'll see you in 6 weeks. So we try to make that interaction easier to do the right thing and educate them appropriately on best practice prescribing standards. And that's in a nutshell what we're doing. The hero here isn't a new drug, it's actually better data. So we're taking that data and our AI-driven platform helps Lenawee County identify where the problem starts, engage prescribers directly, and deliver measurable savings while saving lives. So that's what we're doing. And so this technology was born out of a top addiction center in the United States. Actually, it was in Des Moines, Iowa, where they looked at 7 years ago. They said, well, okay, we have these folks, they've pretty much lost everything by the time they get here. If they haven't lost their lives yet, but absolutely everything else. They've lost their jobs, their families in a shambles. They have, lost a lot of money, any way to make money and what have you. So they decided, well, let's go a little upstream. Let's use their data, look at their clinical data. Since they're our patients, we have access to this information. And let's look at prescribing patterns that led to that addiction for those individuals. And let's model that and integrate that into an AI-driven platform that gets smarter with every prescription and understands this pathway to addiction. Now, 7 years in and over 1 million lives are on the platform, our logic is even stronger and we're saving many lives before addiction begins. We're seeing a 60 to 80% reduction in high-risk prescribing after implementation. Overall, we're seeing health plan savings of 3 to 5% of your overall health plan spend. And 3 to 5% of a big number is a big number. So we could return some money back to you folks because we're preventing these ER visits for more prescriptions. We're preventing these urgent care visits or x-rays so we could justify another opioid prescription. We're preventing additional family practice or primary care practice visits. We're seeing this in our data because we're tracking this with the claims data over time, so we could actually show that this actually is working and making a difference. We're in 26 states now. We have 1,700 employer groups in the program, and we work with Medicaid, county plans, TPAs, and unions. I'm speaking at a national union conference about this very program in a couple months. And we could also help with Michigan's Medicaid program. I'm talking to them right now. Next slide. So what we'd like to suggest is, and where we think we can be very impactful, is we think we can get, these are our objectives if we did a program with you guys, and our key performance indicators or KPIs, we think we can get an 80% prescriber adoption for best practices as we engage with them. We're gonna overpromise and, or underpromise and overdeliver rather. We're getting, like I say, we're 92% right now. So we very much, we're not gonna break a sweat to get about 80% prescriber adoption. We also think that we can get much more than this, but 20% reduction in opioid prescribing per 100 residents for your county as a whole. I think that's going to lower the workload for our sheriff here, and we think we can easily accomplish that based on our ongoing and recurring data that we're getting from other communities like this. We expect a 60% reduction in at-risk plan members that are on the plan that are getting these dangerous opioid prescriptions. And again, we believe we can receive about 3 to 5% in overall health plan savings. On the average, we're seeing a return on investment for every dollar spent on the program. We're returning $3 to $5, maybe as high as $8 per dollar spent to the plan on their overall health benefits spend. And nowadays, everybody's looking for ways to save money on healthcare, and this is a great way to do this, and it helps improve the health of the community. Next slide. To give you an idea, this is what an implementation timeline would look like. Phase one, we do some data sharing. We get baseline opioid impact assessment analysis for your population of workers, your employer, even partnering employers. We could partner with other local employers to do this as a consortium. Phase two would be weeks 11 through 20. We'd do the provider engagement. We'd also launch public awareness and patient education campaigns. You know, the rest of the world is doing this so much better than we are. That's why they have a higher survival rate than we do. We're kind of falling off the cliff compared to the other OECD nations. That is any high performing economy that you could think of that we'd like to call trading partners. And that's because they respect opioids a lot more than we do. They don't use them nearly as much as we do. And we're just weaning America off opioids and getting us back to a prior baseline before these marketing efforts went into effect back in the mid 90s. Phase three looks at claims data. We can continue to analyze even quarterly how things are going, and we can report what we're seeing on the claims data. So we can continually monitor the progress of the program on an ongoing basis. And then next slide. Okay, great. So what we in our application, we actually budgeted a request of about $196,000. What that is, that works out to about $400 for that patient or that provider engagement we talked about, where we engage with, you know, it takes a few emails, a few phone calls, and some efforts. We have a team of pharmacists and other providers that engage with them directly. That's where all the costs are. is in that direct provider engagement. Data is pretty easy. We've got that scaled and we can look that up quickly, but it's that engagement that costs us the money. We are only, that's really a very loose estimate. We believe that is your higher risk prescribed individuals within your county and county plan. And the program, what's great is this seed money really is just seed money, and this could become a self-sustaining program from then on. We renew every 3 years, and we have a renewal rate that's better than 85% nationally so far, because these programs are seeing ongoing savings. All these folks I'm talking about, these are actually private, commercially insured employers mostly. As of right now, we're just really entering into the RFP public space, and this includes both unions, teachers unions, et cetera, and hospitals and health systems in Florida and the Dakotas and others. So these are the organizations we're currently working with. We're just expanding now in government programs. So comparable installs show we're saving about 1.5 million to 2.3 million per 10,000 covered lives. And what's innovative here is that, again, these settlement funds can become seed money for a recurring program that improves, lowers costs for your health plan spend and improves the health of the community in a secondary effect. Next slide. Okay. So why opioid-free America and why now? It's the only prevention-focused AI-driven solution that targets the root cause of our opioid crisis, and that is this overprescribing of Norco and oxycodone and what have you. It works before addiction begins. We found that we're seeing about 10,000 additional dollars with one opioid prescription for a plan in additional healthcare spend. So we're saving that amount of money by intervening early. And it aligns with national settlement core strategies. We easily qualify for those. And I want to finally say that this isn't about statistics. It's about people. It's about saving lives before addiction begins. Thank you very much for your time. I hope I didn't take too long.
No, you did just fine. If the committee would grant me this indulgence, I run a few numbers here and I thought I would ask a few questions. It looks, if I'm doing the math correctly, we're looking at the per employee, you did 1.5 million to 2.3 per 10,000 covered lives.
Yep.
So the savings approximately $150 to $230 per employee.
That's pretty close. Yep.
And we have what, about 600 employees here at the county, which is about 190 to 138,000. How would we see that savings to us? What would that look like?
Yeah, that would be your overall health benefit spend savings on a recurring basis quarterly over time. And again, it's just because your people are just not using healthcare as much. They're not needing to because they're getting off these medications.
But to continue for another year, then, is it again another 100 and?
No, sir. Yeah, it gets over time, it's going to be less and less because we've already, again, improved the knowledge base of the local prescribers. I don't think you're going to have a lot of changeover in those folks. So over time, it's going to cost less money, and it's maybe going to be less impactful, but that will take some time doing.
Well, yeah, you anticipated my question. I mean, you can only educate the providers so many times. And it either takes or it doesn't. So we can't achieve these same level of savings year after year.
Yeah. Yeah. Well,
Presuming a relatively stable pool of
yeah.
prescribers.
Yeah. Yes, sir. I would agree. And again, I want to emphasize we're 7 years into this. We do have a lot of these organizations are renewing with us because of the kind of savings they're seeing.
Super.
For example, I mean, there's about 60 million surgeries that happen every year in America electively, like people get their joints replaced. They have to have a rotator cuff, whatever. That's what I do. I do a lot of that. Unfortunately, because of our overprescribing problem, about 10% of those folks are going to end up end up on opioids long-term. So 10% of 60 million is about 6 million new addicts or new should we say new opioid dependent people just from surgery alone. Okay, so there will be an ongoing problem with surgeons as well, and those are the other prescribers that we're going to be addressing over time. It's even worse with like mastectomy for breast cancer. That's about 20% of those poor gals end up on opioids in 90 days. 40% if they have reconstruction. So that's an ongoing problem as well. We'd like to, that's one of the highest risk groups actually for something like an elective surgery. So there's a lot of different ways we get to, the opioid problem. Tooth extractions is another one. I can give you some data on that, but there are many providers to engage with, unfortunately.
I'll throw out one last one since you went down this line. A number of my friends, like all of us as we age, have friends and family that need palliative care at the end of life. And one of the things that we've seen, the consequence of the exposure of the harms of opioids is that people who actually need these kinds of medications at end of life scenarios are finding it harder. I presume your AI can control for that. And do you have any other thoughts on that topic?
Oh gosh, thank you so much for mentioning that. And none of this discussion today was talking about people that already are on chronic opioids and have problems. That was actually some of the early discussion, I believe. What I'm talking about is preventing the start of the problem. And yes, our data can show that too. And yes, I totally agree. If I have terminal cancer, I want a 6-pack and a fishing pole and maybe some opioids, maybe some bourbon and something, I don't know, whatever. But we absolutely should be giving those people those kind of therapies. And so that's the one problem when you start working with government on solving these problems with these broad strokes, there's unintended consequences that lead to this problem. So yeah, thank you for asking that question. And this has nothing to do with those folks.
Super. Now you folks. Sarah.
Hello. I would definitely agree. My office does see and overdose fatalities. A lot of people, at least what the family tells us, that they started on this journey because they had a back injury. Back injuries seem to be a big thing. Knee injuries, those types of things. The majority of our overdose deaths are middle-aged people in their 40s, 50s, even 60s. So they've already been on some kind of journey with pain or, substance use or whatever. But so I do find this very interesting. I do have a couple questions if we have time. How is this program different than MAPS, the Michigan Automated Prescription System? Different or better? And then also, how do you find the providers? Because I work for doctors. How do you find their responsiveness when you do contact them or your company contacts them with saying, hey, we could do things better, or so comparison with MAPS, and how do the physicians that you contact react?
Yeah, thanks for that question. So is everybody familiar with the MAPS program? I know Sheriff, I'm sure is. So the MAPS program basically is our statewide database that looks at opioid prescribing. And I think we actually have a law that requires physicians to look at the MAPS information on an individual to see that they're not getting prescriptions from multiple providers at multiple locations. So that's just a source of data that is shared by the state. I would say that our data is probably a little more robust because we're looking, our data is not real time. MAPS data is real time, closer to real time. Ours is probably trailing by about 2 weeks. But we're looking at the information a little differently. We're shining a light on the sources of the prescribing, not so much the individuals. Excuse me. With MAPS, they're identifying the individuals and kind of working from there. So that's kind of how that's different. Your second question, I hope that answered that, was doctors.
The responsiveness of the physicians.
Yeah, great question. So, we used to have all the physicians were entrepreneurs in the United States before the High-Tech Act and the Affordable Care Act, and a number of legislative changes led them to really look for help or be bought or purchased by somebody else. So they're either owned by hospitals and health systems or private equity or some other organization now. Almost 75% of them are, about 25% are not. That's probably a little different, I would think, in Lenawee County. I think it's probably a few more are independent. So they're not so much independent anymore. Back in, before 2009, about 75% were independent. So we've had this kind of switch over. So they're employees, they're kind of shift workers. They get annoyed when I say that, but it kind of changes their thinking, and they're trying. I think many of them hit the easy button. They may not be as engaged in that individual as we'd like. We're trying to help them get re-engaged and do the right thing, and they really do when you present it to them in this way. They absolutely want to do the right thing. We've had very good success, and they're saying, thanks, you gave me a better easy button, or an easy button that's helps me do the right thing. And we give them the data to say, look, and in fact, I think you just asked about, middle-aged American males. I think this opioid overdose is the #1 cause of death between 18 and 43, I think. I'm sorry, I don't have the data right in front of me.
I'm pointing to the medical examiner's office.
Yeah, I think that's #1, right? Opioid overdose for that subset of the population. I think it's right up there. Yeah, pretty sure. Yeah, I mean, besides gunshot wounds and car crashes, and all of them combined don't come close, I don't believe, to opioid overdose, unfortunately.
Francie?
Does your information collect from the Veterans Administration? Because going back to MAPS, they're not required to give any prescriptions, the Veterans Administration, to MAPS. So they're not required. So are you able to aggregate that data?
Not currently. Thank you. You've just taught me something. I didn't know that. Seems odd because that's a government agency.
They're not required to, right? Because it's state by state and they're a federal entity.
Yeah,
so they're not
Indian
required.
Health Service too, probably then.
Correct,
Oh,
correct.
interesting. We are working them on a number of other programs, but not with Opioid Free America, but not this one. What we're looking at is only the data that we're getting from the county and other employers that may want to partner. Because again, like any AI, the more data we get, the better it is and the more accurate it is for any community. So we'd love to partner with and create a consortium of local buyers. I also think if we are engaging with doctors and we say, hey, we represent not only the county, but A1 car dealership or whatever it might be, right? So, or this local manufacturer, or in manufacturing, like the building trades and in manufacturing, those are some of the highest opioid folks, opioid use folks there are in terms of a population. I started down this past 7 years ago with the UAW, and they wanted to get some help with their opioid problem. So that's how I got here today. Any other questions?
Terry?
There's a little extrapolation on Sarah's question. You mentioned earlier, and it's probably true, that when you get a chance to talk to one of these prescribers, you have 10 minutes, maybe max. And after you leave, the rest of that day, 3 reps from Big Pharma come in, and they also have 10 minutes. How do you overcome the pressure that they exert? And it is pressure.
Yeah, we're not as good looking either. Thank you, sir. That's a great question. Well, we hope that, we have a more compelling message, and again, to draw home some of these statistics, and they want to do the right thing. They're just a little overworked and sometimes not well educated on acute pain management. That's my specialty care area of interest, of course, as an anesthesiologist. And you're kind of getting at how we got here. I mean, America is a huge outlier in opioid prescribing throughout the world. Nobody else prescribes opioids like we do at any level in any part of the world. To give you an idea, the Annals of Surgery study just like 3 years ago for gallbladder, hernia repair, and appendix surgery at at 9 of the best centers in the world, including one in LA for us, and I think Johns Hopkins for us. We prescribed opioids after those surgeries 91% of the time. The rest of the world, less than 5% of the time. So this is kind of how, and again, we've been marketed to, it was pain is the fifth vital sign in the late 90s, which I experienced with the Joint Commission. 7 states attorneys general are suing the Joint Commission for that pain is the fifth vital sign nonsense. That just, again, it created this demand for a product that nobody should be receiving. With acute pain and acute post-surgical pain, we'd like to decrease swelling and inflammation. It does none of those things. It only masks the perception of pain and then causes many other downstream problems. That's why we love nonsteroidals, ibuprofen, Tylenol, ice. Ice is nice. I tell my patients all the time. So there are better strategies to do this. The rest of the world's got this figured out. The Scandinavia is wonderful on how they deal with opioids. We're basically trying to bring that to America and get us back to a safer community.
So if we signed a relationship with you, how would you get access to the data? What's that process look like?
Yeah, will assume, Francine, you can maybe tell us too. I would assume you're self-funded as an employer. By the way, we don't even need opioid settlement money to start this. We could actually just look at your data from your healthcare provider on claims data, carrier. No? Yes?
The county administrator is
Oh.
here. She'd be the best person to.
I'm sorry. Great. Even better.
Too.
Pardon me?
Yeah, I think the question is, how would your process work for that? And of course, yeah, we have all of the data on our employees with our carrier and such, but I don't know what your process would look like once you got that data. Just kind of walk us down a high level scenario of what the steps would be.
Yeah, so we're doing this right now with Livingston County, actually. And this is outside of, we're just doing it with the county commissioners and their employers, their employees. And so we got their health claims data and we're putting it into our data platform. And we, fulfill all those requirements on HIPAA guidelines and it's protected data and what have you. And there's data agreements that we exchange. And within about 2 weeks, we'll have what we call an opioid impact assessment. We can tell you, well, here's where you're at right now. And we could also estimate the kind of savings you might experience within your health plan if we went forward with that reach out to all those prescribers and what have you. So it's about a 2-week process after that. Then we re-engage you guys again and we'll give you an estimate of what it would cost. And then we move forward and then we measure savings over time.
Thank you. Other questions from the committee? Francine?
So when you were speaking on, you mentioned OxyContin a couple times. Is there any data? Do you get to collect that? And is that a different prescriber since OxyContin was reformulated, right? So did OxyContin lessen and other opioid increased?
Well, they're all bad. Yeah, and the drug companies are always reformulating things so they can patent it and they have some protection and they want to charge more if they can. Yeah, we'll see all of it. And that's the important thing because the more we see, the more our modeling gets better on, where do these things end up? And we can actually see now, we're seeing pre-addiction happening with individuals where we might not even have, like you talked about the VA, we might not even have that opioid prescription, but we could see how some behavior change within the data. And that's really exciting for us. So we're getting smarter and smarter with this information, and we're able to identify, risky, somehow they might be sourcing these opioids somewhere else, is what I'm getting at, I guess, too.
Thank you.
Anybody else? Well, again, first, I come away thanking everybody here for knowing so much more about this than me, because you continually ask questions I didn't even know were on the radar. And I thank you for your time, sir. And
Thank you.
is there anything else that the committee wants to bring up before we start to wind down here? I want to thank Monica for her insights about the next level of paradigm that we're trying to put together here. I look forward to hearing from others as they continue to work on that, because it's obvious the more of these we hear, the harder these problems have become, in my mind anyways. Gary?
Do we just have one presentation at 3:30 tomorrow? Or, yeah, because I've only got one.
Yes, the
One-
you should have received an email that the 3 o'clock withdrew.
Right, yes, I did, but I didn't.
So we have one at.
We show up
3:30.
at 3 o'clock? Or we show up at 3:30? That was my question, I guess, is
I would say,
there's no presentation at 3 o'clock. How does this
does
this work? Or do you want to just have a
well,
general?
look, if
discussion?
people show up early, like people tend to do, but they've been told to be here at 3:30. But we have the meeting posted for 3 o'clock.
That's what I was going. I don't know
Yeah.
if the meeting has been posted for 3 o'clock. And you don't have a presenter though till 3:30. I would look at it as you have an opportunity for 30 minutes of general conversation to talk about some of the other questions and things that you might want to deliberate on before you see your presentation. But because it's been posted for 3 o'clock and we want to comply with the Open Meetings Act, we will probably require that everyone be here at 3 o'clock.
Thank you. And maybe a quick note to the presenter, if they wanted to come a little sooner, we would not be angry with them.
I can contact them because they're coming from out of town, so I
That
don't.
would be great. Anything else before we wrap up, folks? Do we have public comment? No public. Any other comment from anybody? Thank you so much for your time and your commitment to this, and I would entertain a motion to adjourn.
Support.
And moved and seconded. All in favor signify by saying aye.